that we're going to have a question and answer period at the end, so you'll have lots of time to ask questions. And also, just before I introduce Sarah Ferguson, I just want to put this into perspective, that the Lynch syndrome, we're dealing with a relatively rare problem. If you think about colorectal cancer in general, it's probably the third most common cancer, and it leads to death, the second highest leading cause of death, cancer-related. So the hereditary cancers that develop either in Lynch syndrome or in familial polyposis, which is a disease whereby you can develop hundreds or thousands of polyps in your colon and rectum. Those two combined are only, compared to all the cancers, all the colorectal cancers that develop, it's only about 2–3% of all of those. So we're dealing with a relatively rare but significant disease. Now let's go on. I'm going to introduce Sarah Ferguson, who is our gynecologic oncologist for our center. Sarah is, as mentioned, a gynecologic oncologist. She deals with gynecologic cancers, and she's working towards certainly a better understanding of the optimal way to screen for gynecologic cancers in women with Lynch syndrome, and also looking at methods to identify new Lynch syndrome carriers in newly diagnosed endometrial and ovarian cancer patients. And she's going to talk to us just about that, endometrial and ovarian cancer in Lynch syndrome. And for those who don't know, endometrial is uterine cancer. Just wanted to explain that term. Sarah?
Thank you, Zane. So Rob's given us a nice overview of the importance of gynecologic cancer and the shift from calling it HNPCC to Lynch syndrome, because there's other cancers, especially for women, that are very important. I'm just going to review. Some of it will be a little bit of overlap, but there'll be some specific questions that hopefully I'm going to have the answers for, or the best we can do in the literature up there. So I just have some objectives, and we're going to review the lifetime risk of gynecologic cancer. Dr. Greg's gone over this a little bit. To review potential symptoms of gynecologic cancer, and I think this is really important, especially when we lack good evidence regarding screening, and to discuss the data and the controversies of screening for gynecologic cancer. And this is a problem not just in Lynch syndrome, women with Lynch syndrome, but in the general population as well, but we'll specifically focus on Lynch syndrome. And to discuss data on risk-reducing surgery in preventing these gynecologic cancers. So, as you all know, Lynch syndrome is an inherited cancer susceptibility syndrome, and it's characterized by the clustering of these cancers, and the most common being for women being colorectal and endometrial. And it's related to defects in these mismatch repair genes. And as Dr. Cohen stated, that if you look at women with endometrial cancer, so unselected women, so they don't have a strong family history, you just look at all comers, in the literature, it's anywhere from 3 to 5% of women will have a mutation in one of these genes. So small but not insignificant. I don't think that projects as well as I'd like. This is looking really at the lifetime risk of the different cancers up to age 70, and I've looked at the top 3 for women. So what's important is that endometrium and ovary are in that top 3. And if you look at the baseline risk of endometrial cancer in the general population, it's quite low at 2.7%, and with Lynch syndrome, depending on the mutation type, up to 60%, and it's at least as equal, or in some studies, greater than a woman's risk of colorectal cancer. And ovarian cancer is also a rare cancer in the general population. However, it's at least 10 times greater in women with Lynch syndrome, and it likely reflects different, related to the type of gene that they have, with data saying that MSH2 may have an increased risk of developing ovarian cancer. So Dr. Cohen was giving you an anatomy lesson. So what is endometrial cancer? Because no one really knows what the endometrium is. Its other term is uterine, and it's really the lining of the uterus where the cancer develops, as opposed to in the uterine wall, which is the muscle. So I've just shown here that it often starts very small and microscopic and develops into a larger tumor and can be symptomatic at a very early stage in many women. So what's interesting about endometrial cancer and Lynch syndrome? So it's reported over and over again in the literature that if a woman has two primaries that include endometrial and colorectal, in over half the cases, the endometrium is the first cancer, and we call that the sentinel cancer. And what's probably even more important is that there's a really huge lead time, and this also is consistent literature of almost a decade before them developing the colorectal cancer. And this is really important. We haven't been very good at highlighting the syndrome in gynecologic cancer. It is getting more publicity, and there's more education and knowledge amongst general gynecologists and gynecologic oncologists to try to identify these women, because it's an opportunity to actually impact that patient with colorectal cancer screening, because colorectal cancer is more likely to kill someone than endometrial cancer. Endometrial cancer in general is a more favorable cancer, not always, and offers an opportunity also for family members to be identified for colorectal cancer screening and possibly risk-reducing surgery to prevent gynecologic cancer in their family members. And it has been difficult to identify these women for many reasons. A lot of the clinical criteria we have depended on have been really focused on family histories that are really have prominent colorectal cancer histories. People don't know their family histories. Many women have had hysterectomies at younger age before developing cancers. So it's been difficult. And over again, repeated in literature is that probably 2/3 of women who present with an endometrial cancer who actually have Lynch syndrome would not be identified by the current family history criteria that we use to identify people. So endometrial cancer, is it different than the general population? And in general, we think not. It follows, it's somewhat similar. However, the difference is that it presents at a much earlier age, as in other cancers in this syndrome. So the median age of women who develop endometrial cancer is probably around 46 to 48. It's fairly consistent compared to age 63. So in the general population, this is a cancer of postmenopausal women. And actually makes it easier to try to diagnose it, because postmenopausal bleeding seems very abnormal to everyone. Symptoms when people are still having menstrual cycles is much more difficult to differentiate as abnormal. So there's similar types of endometrial cancer as well, meaning all endometrial cancer is the same. The type of cell that actually develops in the cancer can be different, and some are higher risk cancers and lower risk cancers. And the distribution of higher risk cancers from the uterus to lower risk cancers is the same as in the general population, with about a 20% actually having a high risk histology, which likely would require further treatment. So, but not all endometrial cancers are treated with surgery alone, but require chemotherapy and radiation after their initial surgery. Again, there's a similar stage distribution, and why, in general, endometrial cancer is considered, in quotations, a good cancer that people get. It's often told that to patients. I don't think that's very helpful to be told that. Is that they present at an early stage. So 80%, probably 85% present at stage 1 with a very excellent survival. And this is because it's often associated with symptoms, and symptoms early. So women who have reached the menopause, they have bleeding. But symptoms in younger women can be more difficult. So it can be bleeding between periods, very heavy periods, or irregular periods. The second cancer that is common in women with Lynch syndrome is ovarian cancer. And this is just a picture showing the pelvis, a little anatomy, and how cancer can start on the ovary and spread to the areas, the bowel, and other areas within the pelvis. So what is ovarian cancer like in women who have Lynch syndrome? And we do think that this is could be different than the typical ovarian cancer that you have read about, what we call sporadic, or cancer that arises in the general population, or cancer that arises with another group of patients who have a cancer syndrome or called BRCA1, and you may have heard of it through the publicity with Angelina Jolie, being a mutation carrier and undergoing risk-reducing surgery with a mastectomy. They have a very sporadic population, so women who are the general population don't have a mutation, and women who are BRCA mutation carriers seem to have very different cancers than women who have Lynch syndrome. And it's important because it may have implications for screening. As in the BRCA1 population, women with Lynch syndrome have their cancers early, and even earlier than the endometrial cancer. So it seems to really increase at around age 40 to 42. The median age in most studies is around 42, compared to the early 60s in the general population. And unlike the sporadic cancers, the type of cancer, so what the cell is, and I know that's kind of specific, is very different. And that may have significant implication in us being able to hopefully find earlier lesions. And one of the biggest things is that most women who get ovarian cancer in the general population present with advanced stage, with very, very little symptoms, supposedly, until they present and are quite unwell. And so a very small percentage are stage 1. However, in women who have Lynch syndrome who develop ovarian cancer, the majority are stage 1, which is not the general experience, compared to 70% stage 3 and 4 for women who have sporadic ovarian cancer. And it's often picked up incidentally after they're being treated for their endometrial cancer. So they go in for the definitive surgery, their surgery for the uterine cancer, and at that time they're found to have an incidental finding of an ovarian tumor. They may have even better prognosis than sporadic ovarian cancer, and likely due to the fact that the majority of them are early stage. And they may have a more predictable progression from early stage to advanced stage compared to women who have ovarian cancer in the general population or who have a BRCA1 mutation. And this is really important. I think one of the things that Dr. Greif highlighted is one of the ways to have a good screening is that you have to have a predictable progression from pre-cancer to cancer, and hopefully long enough that you can catch something. And it seems, and we'll talk about the literature, there really isn't that process for the more common ovarian cancers. However, we do seem to find in Lynch syndrome that there are different types of tumors, and that more often in stage 1, and perhaps that allows a window to actually detect these on some type of screening process. So I think what's really important is that you, women with Lynch syndrome, know more about this syndrome than most physicians or nurses or healthcare professionals, and you need to advocate for yourself to have investigations for abnormalities. So if someone still has a uterus in place and they're postmenopausal bleeding is not normal in anyone, it needs to be investigated. Bleeding between periods, heavy periods or irregular periods, someone needs to assess and ensure that this is not just a hormonal thing, but that they have to rule out something in the uterus. And the only way to do that is to get a tissue sampling. So ovarian symptoms are also important. Everyone, ovarian cancer was called the silent killer. There's been research, very good level 1 research about the fact that most women do have symptoms before they are diagnosed with ovarian cancer, and they're not gynecologic. They're non-gynecologic, and they're very consistent. So bloating, pelvic or abdominal pain, difficulty eating or feeling full quite easily, or urinary symptoms. So having to go to the bathroom more often, and urgency, sorry for the typo. These are obviously not very specific, but they warrant investigation, especially with someone who's at a higher risk. It shouldn't be dismissed, and that may be an exam or some kind of imaging to rule out anything going on in the pelvis. So what investigations should be performed if these symptoms occur? Well, physical examination to start, but abnormal bleeding should have some type of endometrial sampling done. And this can be done in the office. It is fairly straightforward. It does have discomfort or pain. It's usually short-lived. And I would say that 99.9% of women do fine. I don't think it's pleasant, but I don't know if a colonoscopy is either. Sorry, I don't need to. You don't have to have a bowel movement, that's good. Or a D&C. A D&C isn't wrong, but if it's going to create a significant delay, I think that that's not okay. Ultrasound could be performed. It is not ideal. It doesn't make a diagnosis, and it certainly shouldn't be used. Often what happens is people are, imaging is ordered and they wait for that, and then time goes by before someone actually just gets tissue to know what's going on. So ultrasound's fine, but it should not delay sampling of the endometrium. And so sometimes you need to advocate for yourself to get to a doctor that can actually perform these tests. Again, bloating, abdominal pain, difficulty eating, or any urinary symptoms that are persistent. So this is, everyone has these symptoms, but they're persistent, worsening over 2 to 3 weeks. Ultrasound is very helpful and is probably the best modality to look at the ovaries. And CD125 is kind of like what Dr. Rick was talking about with PSA. It can be a problematic test. It's not a diagnostic test for ovarian cancer. It should not be performed without someone understanding the limitations of the test, especially in women who are premenopausal. Many things can cause an elevated CD125, having periods, having fibroids, having a pregnancy, having endometriosis. So it should be done with someone who can actually interpret it and kind of put it in context. So I put a picture here of an office endometrial biopsy, so PIPAL. You can see here on the right, it's like a very thin straw, thinner than a straw, and a normal pelvic exam is performed, and this actually goes right into the uterus to try to get the sampling of the lining of the uterus. The other is a transvaginal ultrasound. So why not a pelvic ultrasound as opposed to transvaginal? Well, the reason why transvaginal ultrasound gives us such great images is that you can actually get very, very close to the ovaries and get very accurate images of what's going on in the ovary. So I'm going to just talk a little bit more about screening for gynecologic cancer in women with Lynch syndrome. Ideally, we want to find pre-cancerous lesions or very early cancerous lesions to minimize morbidity of treatment, i.e. requiring less extensive therapy, and decrease mortality from cancers. As Dr. Rev said, we have evidence that colorectal cancer screening in the general population and in individuals with Lynch syndrome decreases colorectal cancer-related deaths and morbidity because of that ability to find these precancerous or very early cancerous lesions. So what do we know about screening for endometrial cancer? There is an early precancerous lesion, and there is a stepwise development from precancer to cancer for most types of endometrial cancer, for about 80% of endometrial cancers. There's still those 20% of high-risk cancers where we don't know if there's that nice sequential step from a precancerous lesion that causes symptoms to a cancerous lesion, but for the majority there is, and therefore there's the potential to screen patients. I'm not saying there's data to say that we should do it, but there's a potential to be able to identify these early lesions and minimize treatment by preventing advanced cancers. So, as was said earlier, there really is no data on endometrial cancer screening actually in the general population. And we really do not recommend screening by sampling of the endometrium in the general population. And probably for good reasons: low prevalence of disease and a high rate of symptoms even with the precancerous lesions. Those symptoms are postmenopausal bleeding, resulting in either diagnosing the precancerous lesions or a very early cancer, and likely screening wouldn't impact survival in any way in the general population. Well, there's very minimal data, less data in women with Lynch syndrome. Problem is the average age of women with endometrial cancer with Lynch syndrome is in the premenopausal range. So when I say the median age is 46, that means 50% of women are having endometrial cancer at less than age 46. And so abnormal bleeding symptoms is not really a reliable indicator of a problem. There is a higher prevalence of disease in this population. So there may have a benefit in this population, but like was said earlier, there are very few studies and very few good studies. Actually, there aren't really any good studies. So most of them are retrospective and they're very problematic, so I'm not reviewing them. There are 2 prospective studies, so meaning that they plan the study and decided what they're going to do. They don't just go back to the charts and try to figure stuff out. But 2 prospective studies which looked at ultrasound and endometrial sampling. And what they did find is that there was an increased rate of detection of precancer when endometrial sampling was added. So one of the studies, they started with yearly sampling and they picked up nothing. But interval cancers, so cancers between screenings, did develop. They decided to add in endometrial sampling once a year, and they were able to pick up precancerous lesions and cancerous lesions. And they found, in these 2 studies, both of these studies showed that if they had just relied on the ultrasound, 66 to 100% of these lesions would have been missed by ultrasound. Ultrasound for the endometrium or for uterine cancer is dismal. I mean, it's often just a thickened lining. It's not appropriate on its own. So there's absolutely no data on whether this intervention saves lives or decreases the amount of treatment people need. What we do know is we likely could detect precancer or cancer, but it would be very hard to have the numbers to show an impact that they have with colorectal cancer screening, and I don't think we'll ever have that data. So screening for ovarian cancer. So there's really great evidence in the general population, level 1 evidence, and in other high-risk populations like Lynch syndrome, so the BRCA1, 2 mutation carriers, there's absolutely no benefit to screening for ovarian cancer with the traditional means we have now, which is ultrasound and CA125. So it makes it easier for people the recommendations in those 2 populations. And actually, the studies have shown we cause harm by doing that, because there's a lot of false positives and there's a lot of surgeries performed for supposed abnormalities of the ovaries. And there was increased procedures, but also harm from those procedures, so complications. And these results likely due to the fact that in these 2 populations, so the BRCA and the sporadic ovarian cancer, not Lynch syndrome, most present with advanced disease. And they develop quickly, so they would have a normal screen, and then within 6-month interval, they would develop advanced cancer, likely because we don't understand or there isn't a detectable precancerous lesion. So screening for ovarian cancer in women with Lynch syndrome. Is ovarian cancer a different disease than Lynch syndrome? We do see, in general, there's a different histology, and more present with an early stage, and therefore perhaps there's a longer preclinical stage that we could detect on imaging. And could there be a benefit in this population? So there's a much lower prevalence of disease compared to BRCA1/2, and there's a smaller number of women with Lynch syndrome, so I think it will be hard to ever have the data to confidently say, as I have with the BRCA1 and 2 population, which is at increased risk. And there's a significant rate of interval cancers between normal screening tests. So one of the issues with screening, and I think Dr. Breyer talked about this with the cytology, with the bladder cancer, or the GU cancers, is that a normal screening test can give some of the false sense of security that everything is fine. So consensus guidelines, and these are the European and CCN guidelines, multiple guidelines, is that there's no evidence to support screening for endometrial cancer. However, all of them say that annual endometrial sampling is an option to screen for endometrial cancer and is often recommended by expert consensus. And they also state that there may be circumstances where ovarian cancer screening may be a benefit, but there's no evidence to support that, and that possibly screening with transvaginal ultrasound to look at the ovaries, and possibly using CA125. So what can be done to prevent gynecologic cancers? So there is actually good literature looking at what we call risk-reducing surgery, which would consist of removal of the ovaries, the fallopian tubes, the uterus, and cervix. And there was a study that compared women who had risk-reducing surgery, those who had not had any surgery and just had surveillance of some type or no surveillance. It wasn't really, it was a retrospective study. They weren't randomized for the reasons that Dr. Gray said, is that if people want me to go south, you couldn't really say no. So no cases of gynecologic cancer in those that had surgery. 33% developed endometrial cancer in those that were followed or who did not have surgery, and 5 developed ovarian cancer in the non-surgery group. And again, the endometrial cancer median age was 46 years, and ovarian cancer median age was 42 years. So 50% of those people are having those cancers younger than 46 and 42. So there is a very strong recommendation that women undergo risk-reducing surgery when they completed childbearing. This is not an easy decision. It's a lot of discussion. It's very personal, but that there is a lot of literature that we can prevent cancers and possibly prevent deaths by risk-reducing surgery. And we've seen this in the BRCA1 and 2 population as well. So the recommendation is removal of the uterus and the ovaries by age 40, because that risk of ovarian cancer, though it's much smaller, some say with MSH2, 24% lifetime risk, overall 12%, it does start increasing at age 40. And right now, we're not able to identify those who will or will not have ovarian cancer. And we do kind of treat it as a, one treatment for all, but unfortunately, right now, that's the best we can do. So it is difficult to give a recommendation based on a specific mutation. And if there is no cancer history, so no breast cancer history or no endometrial cancer history, we can replace with estrogen. And I think that's one fear that women have. And usually we can continue that until women reach the average age of menopause, which is age 51. So this is just a little algorithm of what I think makes sense with regards to preventing gynecologic cancer, is that women who have completed childbearing and are 40 years of age or older to be offered and discussed risk-reducing surgery. Obviously, there are some individuals who may be too high risk for other reasons, other medical reasons, other surgical reasons not to undergo this surgery. And obviously, there's personal decision-making, and this is just a recommendation. So for women who are younger, we usually recommend starting around age 30 to 35 or 10 years younger than a woman in your family who's had gynecologic cancer. So, but usually around age 30 to 35. And in that age group to offer as a kind of a temporary means to monitor for any cancers. Because especially if we're able to pick up the pre-cancer, we can treat those sometimes hormonally without a removal of the uterus and hopefully preserve fertility. And obviously in the interval, we're recommending yearly interval, but we know interval cancers, so cancers between surveillance can occur. So it's very important, even though endometrial biopsy is normal, ultrasound is normal, that if there's new symptoms that are concerning, that you are investigated right away. So in conclusion, all abnormal symptoms need to be investigated because of the increased risk of endometrial and ovarian cancer, and that there is no real documented benefit. And what we say with screening, we want to show that we prevent cancers and save lives. There isn't that data for routine surveillance. However, so what we're saying is I don't want women to think that they can do surveillance and continue without a risk having their uterus until they're age 70. Really, we do think that the benefit is with risk-reducing surgery, and that we use surveillance in those women who haven't completed their family or are not in a situation where they know if they want to have children, to keep the uterus in place and the ovaries in place until they're at a stage where they can come to that decision. So surveillance is really a temporary measure for those who have not completed their families. And hormone replacement therapy, because I think that's really a worry for people to be without estrogen at such a young age, can be given after risk-reducing surgery. Obviously, it's individualized depending on the patient's history, so that would have to be taken into consideration.